Hello, everyone, and thank you for joining us. We are going to be focusing in this webinar on the healthcare sector, the lack of staff engagement, particularly frontline clinical staff, in quality improvement activities in the healthcare sector. And these are issues that are happening across a range of sectors, not just healthcare. And there have been quite a lot of reports most recently, and you can see on your screen now there's a slide from the report prepared by Professor Stephen Duckett in Victoria about issues around preventable patient harm. And one of the things that he mentions in that report is the contribution of lack of engagement by frontline clinical staff in the issues that underpin the preventable patient harm. And that's an issue that I will be going back over to talk about through the course of this webinar. The idea of continuous quality improvement, this is an idea that has been around for really quite some time. In manufacturing sector, I think it actually started in the 1920s and 1930s, whereas in the health sector, it really didn't catch on until the 1980s and 1990s. The term is used very widely today, probably because intuitively, it looks like what we should be doing. That is, continually looking for ways to do things better. And when you read the theory of continuous quality improvement, you see that one of the underpinning principles or pillars is meaningful engagement of staff or workers in the quality improvement activities of their workplace. There are other pillars, of course, as well, but this is the one I particularly want to focus on. But as Phil had alluded to, and as I reiterated in the comments that you may not have heard of his, this lack of staff engagement in quality improvement has been cited as an issue in report after report, particularly in the healthcare sector. And in fact, it's such a problem that it makes you wonder if anything even remotely resembling continuous quality improvement is happening at all, or if it's just a term that we're using because it sounds good. That's not to say that there has been no progress in quality in the health sector or other sectors in recent times. Indeed, in the healthcare sector, we've spent a couple of decades focusing on a raft of things that are meant to improve the quality and safety of the patient experience. So we've got standards, accreditation regimes, performance indicators, patient satisfaction monitors, clinical governance frameworks, and so on. And while there has definitely been improvement in the quality and safety of healthcare, we still have an unacceptably high level of quality failures, with roughly 1 in 9 hospital admissions experiencing an adverse event, and roughly half of those likely to be preventable. And, not coincidentally, I believe, the lack of staff engagement in quality improvement continues to be an issue. Well, perhaps we believe that if you build it, that is, if you build accreditation and performance monitoring regimes, then they will come. That is, staff will automatically be engaged in those processes. But I think there's now ample evidence that that really isn't the case. Today, I'm going to be telling you about an approach that we've been trialing where we have had success. But before I do that, I want to talk for a little bit about how it is I believe our existing approaches to quality have actually contributed to the staff engagement issue, because it's those realizations that have informed the design of our approach. And while my comments reflect our experiences in the healthcare sector, they may be just as applicable to other service-based sectors as well. So the first issue is that somewhere along the line, quality has been reframed as mostly, if not entirely, a compliance issue. And rightly or wrongly, compliance-related activities are seen by frontline staff as burdensome and something to either avoid completely or just get through as quickly as possible. Of course, in reality, compliance-related activities like compiling evidence portfolios and filling in forms is not really the kind of work we want to fill up a clinician's time with. But nevertheless, by rolling quality into the compliance domain, we're effectively saying we don't expect frontline staff to be engaged in a big way, and frontline staff are just as happy not to engage. The second issue, which follows directly from the first one, is that the responsibility for quality within healthcare organisations has been handed over to specially designated quality units. Now, on the one hand, the establishment of quality units has been a really good thing because it elevates quality to something of visible importance to the organisation. And the existence of such a unit also provides a mechanism for implementing organisation-wide solutions and for ensuring both efficiency and consistency in the approaches that are implemented. However, on the downside, this has had the unintended consequence of ensuring most frontline staff see quality as someone else's business, not as something that's integral to their own business, and therefore not something that they really need to engage with. And this state of affairs has unfortunately been exacerbated by frontline staff workloads that make little or no allowance for meaningful contributions by them to quality activities. And then the third issue, which also follows from the first issue, is that our compliance-oriented approach to quality, with its focus on successfully passing periodic accreditation, audits, and performance reporting, has made quality-related activities separate to what frontline staff routinely do. So their daily job is patient care, of course, and then every so often they're expected to do quality as some kind of an add-on. Now, these features of our current approaches, of course, have other consequences. Because we have dedicated quality units, we then expect those quality teams to not just compile evidence portfolios and fill in the various forms, but also to collect, analyze, and report on a range of data, and then develop and implement quality initiatives to address any problems they've identified. Now, this is not intended as a criticism of quality managers and quality teams who, in my experience, are dedicated and hardworking people. But the problem is that this arrangement results in a very top-down approach to quality improvement, with people who are not actually involved in frontline service delivery tasked with responsibility for improving the quality of the services delivered by others. And what very often happens is that the frontline staff end up feeling that the various quality initiatives being rolled out by the quality team are being imposed on them from above. They complain that their input is on what's wrong is either never sought or, worse perhaps, is sought but then disregarded. Even if the quality unit's initiatives make sense and are well implemented, frontline cynicism usually takes its toll, and the expected benefits from the initiative are either not realized at all or are short-lived. Indeed, I think that what we perceive as cynicism on the part of frontline staff is probably mostly a reflection of their lack of engagement in the process. That cynicism is most often seen in staff surveys, where frontline staff either don't bother to respond at all, or they may provide narky, unhelpful feedback. And understandably, management then perceives that frontline staff are only interested in complaining and have nothing of value to add, and so even less effort is put into meaningfully engaging them on quality. And before you know it, we have a self-perpetuating cycle under the broad rubric of lack of frontline staff engagement in quality improvement. Now, the reason all of this is important is because if we want to change the situation, then we have to target those aspects of the system where our efforts are most likely to have the desired impact. And I would guess that those health services that are winning the war against preventable patient harm have found a way to do precisely that. So, for instance, I don't for 1 minute believe that we're going to be able to uncouple quality from compliance, and I'm not sure it would make much difference anyway. The reality is that compliance activities like accreditation and performance monitoring have an important contribution to make to quality and safety, particularly in healthcare. And I definitely don't think the answer is to get rid of quality units. Indeed, I think that quality teams have a vitally important role to play in enabling and supporting meaningful frontline staff engagement in quality improvement. But where I believe we can have the most impact is in changing the attitudes and behaviors of both staff and management in terms of seeing quality as integral to the daily practice of frontline staff. And that's what our approach is based on. So what we have been trialling in a Melbourne hospital involves regular, structured conversations amongst teams of frontline staff about their daily practice. The conversations are organised around the national safety and quality health service standards and uses a technique that we have developed called Map-Enabled Experiential Review, or MeER. We have a peer-reviewed article on this technique coming out in November, and I've uploaded a preprint of the paper in case you're interested in reading it, and you'll find that in the handout section on your control panel. I've also included a copy of our paper that was published last month, detailing the use of the MeER approach in a successful quality improvement initiative in clinical education and training. Now, the MeER technique can be implemented as a low-tech pen and paper exercise, but we've actually developed an online tool called Meerkat that makes the technique interactive, allows the technique to be scaled up across a whole organization, and also enables seamless integration of various steps, as well as providing easy to generate reports. Regardless of whether you are taking a low-tech or a high-tech approach, at the heart of the MeER technique are graphical maps or process models that represent the process or system of processes that's being reviewed by the team. Importantly, the map provides structure for the conversation between team members, as I'll show you in a moment. So here is one of our process models created in Meerkat. We call these base maps. This is the process model for NSQHS standard number 5, which in version 1 of the standards addresses patient identification and procedure matching, as you can see on the label at the top here. As you can see from this legend down in the lower right-hand corner, the color-coded rectangles, which we call nodes, show the inputs, activities, outputs, and outcomes by which a health service would achieve the objectives of the standard. Now, I don't imagine that you can see this map in any particular detail on the screen, and so I've included a PDF copy of the map as a handout for you, which you might want to look at after the webinar. So now I'm going to show you how the MeER technique works using screen grabs from our Meerkat system to demonstrate. So the team that is conducting their assessment would have this map projected on a wall using a data projector. Clicking on a node, such as the one that is highlighted here in yellow, clicking on that node would open a dialog box, which I'll now show you in more detail here. So the dialog box is designed to lead the team through a structured conversation about how well this particular item is being achieved. Now, you can see that this node is an input, in this case, health service policies on patient ID, and there's more information about the input as well as a rating question revealed when you click on the read description button. You can see that there is a rating scale down here, and this is what the group uses as they discuss how they experience this particular input, both individually and also as a team. Now in Meerkat, this interface is clickable, and that allows the group to register the ratings of individual team members on the node rating card while they're going through their discussion. They're also able to add comments and attach documents that support their ratings. When they've finished their discussion, they click on that green next button and move on to decide on an overall consensus rating for the node. And then they click next again to move to the final step, where they decide whether they want to include this node in a quality improvement action plan. Now you can see that the tool makes a suggestion about this, and that suggestion is based on the poll ratings as well as the consensus rating, but the team is able to override the suggestion. So when they click on the done button, you'll see that an icon appears in the top right-hand corner of the node in the map, and that icon reflects the consensus rating that's been assigned by the group. So in this case, because the consensus rating was either an average rating or a below average rating, the icon is an orange hazard sign, whereas if they had given it an above average consensus rating, it would produce a purple tick. Now, when all the nodes in the map have been rated, you can see that the team has effectively an instant snapshot of where issues relating to this standard that require attention have been identified. Meanwhile, any nodes that they nominated to include in their action plan appear as cards in the to-do column of the integrated action plan tool in Meerkat. Each card can be opened, and tasks to address the identified issues can be added, assigned to individuals, and given a due date. When the tasks get underway, they can move the card, drag it and drop it into the in progress column, Tasks can then be marked as completed, and when all tasks on a card have been completed, they can drag it and drop it into the done column. Now, Meerkat also includes reporting functionality, as I mentioned earlier, and this allows the team to produce a node-by-node summary report on their assessment, and if they were to repeat the assessment in a few months or a year's time, they can compare the later assessment to the earlier one. If other clinical units within the health service assess themselves against the same map, there's a report that compares the consensus ratings between units, and you can imagine that this is very useful if you want to distinguish local issues that require local solutions from more widespread issues that might require an organization-wide solution. So that is how the MEER technique is implemented using Meerkat, and we have been trialling this technique in 2 clinical units of a Melbourne hospital, specifically the emergency department and an inpatient ward. The trial has been underway since January of this year and is about to conclude at the end of October. 5 of the version 1 NSQHS standards are included in the trial, as I've listed here, and of course each standard has its own unique map. Now, in terms of the logistics of implementing this approach, staff in each participating unit meet once a week, Tuesday afternoons in the ED, Wednesday afternoons in the inpatient ward. They meet for about 35 minutes during the afternoon handover period. Generally, anywhere between 8 and about 12 members, staff members attend each session, and the members of the team take it in turn to each week to drive the tool and facilitate the discussion. The tool is in fact very easy to use, and so virtually no training of staff is required. Nurse unit managers attend as often as possible, as does the director of emergency medicine in the ED. Sometimes members of the quality unit come along, or even senior managers from the organisation will come along to watch, and sometimes they even take part in the discussions. With as little as 35 minutes per week, it usually takes 4, sometimes 5 sessions to complete the map for each standard, and so we've been getting through the standards at a rate of 1 per month. For the trial project that we have underway at the moment, we are repeating the series of 5 standards twice over the 10 months of the project, so that we can see whether there have been any improvements in the 5 months between the first and second assessments against each standard. But in the normal course of events, we wouldn't recommend that a team repeat an assessment against a particular standard more than once every 12 or 18 months. Indeed, we now have maps for all the version 1 NSQHS standards and are finalising the maps for the version 2 standards. And so it would probably take a team at least 12 months to work their way through a complete set of those NSQHS standard maps anyway. So in essence, what is happening here is once a week, a group of staff who work in the same unit are sitting down together to discuss what they do in the course of their normal daily practice, why they do it that way, and how they think they can do it better. Interestingly, the terms quality and quality improvement are rarely mentioned, which I think is actually a good thing, because it means that the staff are starting to see quality as a descriptor for how they do things, rather than as a separate thing in itself. Without being prompted, the conversations have been honest, respectful, and no blame. The knowledge, experience, and expertise of everyone is valued, and everyone gets to have a say. The group decides on the consensus rating for each node, as well as whether or not the nodes should be added into the action plan. And interestingly, they sometimes actually add nodes into the action plan that they've rated pretty well. But they do this because sometimes in the course of the discussion, they realize that there's something that they can do better. And you know, this is what continuous quality improvement actually aims to achieve. Not waiting for a crisis or problem to spur action, but trying to do something better simply because you can. The group is, of course, responsible for identifying actions to address any of the problems that they've identified, because it's not just about coming along with a list of complaints or issues, it's also about devising solutions. Just watching a session, it is obvious that the MEER approach is very engaging for staff. Actually, I did wonder whether the staff would get a bit bored with the technique after doing it every week for 10 months, particularly as we have repeated each of the 5 standards after only a few months. But that's not what has been happening. If anything, the staff in both the participating units are more engaged and involved now than they were in the first half of the trial. And indeed, a couple of staff members who were a bit skeptical, perhaps a bit cynical even at the start, and they didn't want to participate, they are now regularly joining in and indeed making valuable contributions. Importantly, we have more than just anecdotal evidence that the approach is engaging for staff. We have conducted pre- and post-implementation surveys of participating staff, and this next slide shows some of the data from Survey 1 that was conducted 2.5 months into the project, and Survey 2 that was conducted at the halfway point. And you can see from these results that an overwhelming majority of staff participating in this trial, like the graphical map-based approach, learn new information about the national standards as well as about their hospital's policies and protocols. And they enjoy participating in the discussions, including sharing their own opinions, hearing the perspectives of their colleagues, and also reflecting on their own clinical practice. What's more, as you can see here, nearly 60% indicated that they've actually put their hand up to assist with action plan tasks. Participating staff also indicated an improved awareness of quality in their unit. They indicated that there are more informal discussions taking place around quality within their unit. And importantly, they believe that there have been improvements in practice as well within their unit. When they were asked to compare their current level of interest in quality to before their participation in the Meerkat sessions, by the midway point in the project, a staggering 88% indicated that their interest had either somewhat or greatly improved. And it is worth noting, as this trial project nears completion, that both the staff and the managers in the 2 participating units are very keen to continue rolling out Meerkat after the project has finished. So at this point, you might be sitting there thinking, well, this is all very well, and yes, we are seeing some real improvement in the engagement of staff, but is this actually making any difference where it really counts in terms of improving quality and reducing avoidable patient harm? Well, the short answer is yes, it is. Now, I'm not able, unfortunately, to show you the graphs as they have not yet been approved for public release, but we have been looking at the number of adverse incidents reported in the hospital's incident management system across the 5 standards included in the project, comparing the number of incidents in 2018 to the number of incidents reported for those same standards in 2017, that is before the project started. And I can tell you that there has been a highly significant decrease in the number of adverse incidents in the 2 participating units compared to the rest of the hospital. So the data from the trial demonstrates 2 key outcomes. Firstly, the MEER approach has delivered genuine and sustained engagement of frontline clinical staff. And secondly, use of the approach is associated with a significant improvement in a key performance measure, namely the number of adverse incidents. Now, importantly, it is the nature of the engagement that has contributed to that performance improvement that has been observed. The MEER approach is not just some kind of token staff engagement exercise. It's what you might call deep dive engagement, but conducted on a regular basis and incorporated into the normal working week. Staff enjoy the process because, well, it's all about what they actually do, and also because the maps help them to understand the national quality and safety standards in terms that they can absolutely relate to. You know, most people do enjoy talking about their work, and that's what these structured conversations do. They get people talking about what they know best and treats their knowledge, experience, and expertise as something of value to the organization. And the reasons why this type of meaningful engagement produces performance improvements are very similar to the reasons why the technique of in situ simulation is also a very useful tool for quality improvement. Except, of course, that the MEER approach uses a format that is more adaptable and accessible and therefore less costly and resource intensive than in situ simulation is. So first and most importantly, the approach encourages reflective practice by the participating staff, both as individuals and collectively as a team. A no-blame approach to discussions, as I indicated, takes place, encourages everyone to think about what they do in their routine practice and why they do it that way, and then to honestly rate the collective performance and behaviors of the team. Importantly, the data suggests that they are carrying that reflection out of the discussion sessions and onto the floor. Secondly, the sessions are educative. The node descriptions explain the importance of the various aspects of daily practice in achieving the objectives of the standard, and in many cases this serves to inform staff about things they either were not aware of or had long since forgotten. Of course, when staff understand why they're meant to do things in a particular way, they're much more likely to do it that way. And the conversations are not just educative, they're structured. If the nurse unit manager were to sit the team down for a discussion about processes related to patient identification, well, where would they begin? And how would they ensure they discuss everything, not just the obvious things or the pet issues of individual team members? Fourthly, the sessions help the team members to identify where their daily practice is deviating from standard protocols and rectify their instances of protocol variance before a catastrophic outcome brings that variance to their attention. Fifthly, the use of Meerkat allows the team to immediately translate the issues that they have identified during the assessment into tasks within a quality improvement action plan. And importantly, this helps them to see the quality improvement part of the process as directly related to their own daily practice, rather than as an abstract set of activities that have been imposed on them by someone else. Related to this, staff develop a sense of ownership about both the diagnosis of the issues and the resolution of those issues. Instead of seeing quality improvement as the business of the quality manager or the nurse unit manager, they start to see it as their own business. And finally, the sessions help to build what's known as the collective competence of the team, as they develop a shared understanding of the work practices that they contribute to. So in conclusion, all those reports over the years that said that the lack of frontline staff engagement in quality improvement is a major contributing factor to patient harm in the healthcare sector, well, those reports were probably right. And as we have seen from the trial that we are conducting, that when you do meaningfully engage staff, you can in fact reduce the incidents that do contribute to preventable patient harm. The problem, of course, is, as we now know, is that turning around the issues with lack of staff engagement has been easier said than done. What I have shown you today is evidence that our mere approach to staff engagement, which faithfully reflects the ideals and intent of the continuous quality improvement movement, has genuine potential to succeed where other approaches have not.
Yeah, we've had one question come in from Paul. He asked, what do you see as the role of the quality unit in rolling out a Meerkat approach?
Right, well, that's actually an excellent question. So I think that the quality unit is critically important to rolling out an approach like this. So you would want the quality unit to be assisting the various wards and units of the hospital to set up their conversations each week. You might even want them to come along. It would be helpful if they were there and listening to the conversations, because in that way they serve as the sort of glue right across the organization, you know, the conduit through which the different wards are, you know, providing their feedback effectively into the organization. And, you know, they would be able to say, oh, yes, you know, interestingly, yesterday I was over here in ward such and such, and they were discussing the same issue and they came up with this idea. What do you think about implementing that here? So it provides a really important conduit for sharing of information around the organization about the problems that they're having and the solutions that they're coming up with. So I think that the quality unit has a really important role to play in facilitating having these discussions and in also taking part in those conversations. I also think that, you know, when it comes time to undertaking the various quality initiatives that fall out of this, if the individual areas are saying, oh, well, we think we can do X, Y, and Z in order to address these issues, some of those things might be local solutions that need to be implemented locally, but the clinical staff, you know, they have a clinical workload, and that's what takes up most of their time. So if the quality unit can help them to roll out the various different initiatives that they come up with, I think that that would be very useful. But also, if they're hearing that there are similar solutions that are needed across the organization, that's the kind of project you then take on centrally, and you say, we're going to, you know, come up with the initiative and roll that out across the organization. So I guess in a nutshell, I would say I see the quality unit as being, you know, essential for facilitating this, but the idea is that they're working in partnership with their frontline clinical colleagues to diagnose where the issues are, but not just issues, diagnose where they could do things better, and then to help the clinical frontline areas to implement the solutions to those problems. Thanks, Paul.
Thanks. We've had another question, which is how much extra staff time is required to implement this?
Yeah, look, that's a good question as well. Now, what I have to tell you is that in the trial that we have been doing at this Melbourne hospital, there has been no additional staff time because we are actually working in the afternoon handover period where you have double staff rostered on anyway, and we're using a part of that time, 35 minutes out of that time. And so rather than the staff just sitting around chit-chatting about what was on, you know, the block last night or whatever, they're actually sitting there and having a conversation around quality. So there was no additional staff time that was used. I mean, obviously, you know, if you identify that there are particular actions and activities that you want to implement to address any issues, staff time is needed to implement those, to roll those out. But that's true no matter what the source of the ideas are for quality initiatives. You still have to have staff time engaged in that. So it's really about when you schedule the structured conversations. And as I say, I think that most hospitals make use of handover periods, and during those staff overlap periods is a very good opportunity to make use of the staff double time there.
Thanks, Don. Another question is about, would this approach work in, or have you tried in other settings, community health settings, for example?
Look, we haven't. We've actually had some interest from some quality health, some community health services, but we haven't deliberately trialed it there. But I actually think that it would work extremely well in community health. I think it would work extremely well in aged care, in fact. And we do have maps for the residential aged care standards and also the home care common standards. We do have, in South Australia, we have a provider of home care, aged care services is actually using Meerkat as their quality improvement system.
Another question just about the role of senior management in this. Like, do you, yes. Have they been involved, and has there been reports that have gone to senior management?
Yeah. Well, look, I mean, obviously, if you want any initiative to work within an organization, you need to have the buy-in of senior management. We do have the buy-in in the hospital that we're working in, and they are aware of the project and interested in the outcomes. But obviously, you know, this is not something that you want to be doing without senior management knowing that you're doing it. You want it to have not just their blessing, but you want it to have it's got to be championed by senior management. They have to be saying, you know, yes, this is the approach that we want. We want the staff to sit down and be, you know, deep dive engagement with quality. We want these structured conversations. It would be ideal. I mean, in my ideal world, I would be having my you know, senior managers taking it in turns to go to different wards or units within the hospital and sit in on these sessions from time to time, because then it shows the staff in a real and tangible way that senior management is interested in what they have to say and has great buy-in to this initiative. So I think the buy-in of senior management is essential for its success. Their routine involvement can be, you know, limited. It could be, you know, making a tour of the units from time to time, but definitely you do want to have their buy-in.
Thanks, Donna. Look, that's all the questions that we've received. So, look, thank you very much. If people do have questions afterwards, please feel free to email us if something comes to you. So we're certainly like to hear if you have any thoughts. I believe there's a follow-up survey that we'll be asking, just a very brief survey after this comes.
Yeah, and look, for those people who did indicate that you think you might be interested in such an approach within your organization, if you'd like to find out more, there is a survey that comes out to you pretty much immediately after the webinar. And there's an opportunity for you to provide contact information to us, or just to indicate in your comments there, please give me a call. I'd like to talk about this more, and we're happy to contact you and discuss it in more detail.
Great. Well, is there anything else to add?
No, I don't think so. No, that's it.
Well, I hope you found today's presentation informative and useful. And look, we're continuing on, and the next, I think we've got a webinar planned perhaps in early December. So you'll probably be hearing from us about that one. And thank you for your time today, and goodbye for now.
Thank you. Bye-bye.